So, thank you for inviting me to deliver the keynote speech for the Global Public Health Conference, GLOBEHEAL 2025 in Bangkok in beautiful Thailand. I'm honoured to be here amongst so many learned and experienced colleagues from across the globe. My name is Dr. Julia Morgan, and I'm the Associate Professor in Public Health and Wellbeing at the University of Greenwich in London, the United Kingdom. And I'm also the Deputy Director of London's UBEL Doctoral Training Partnership. The focus of GLOBEHEAL 2025 is community engagement and empowerment. And that's what I'm going to speak about today. So as you can see, the title of my presentation is Community Engagement and Empowerment, Empowering Underserved and Marginalized Communities. Throughout the presentation, I will refer to key concepts such as what is community engagement, what is participation, and what is empowerment. And I'm going to relate it to some of the work that I have carried out focused on underserved and marginalized communities. I've been working in community development for over 30 years. I can't believe that I'm saying that, but I have, over 30 years. And I started off focused on the UK, and then I broadened it out to more global concerns. So my research also focuses on centering community voices and community experiences and understanding their perspectives. Oops. Okay. So what do we mean by community engagement? That's the first thing we need to think about. There are many different definitions of community engagement, but I'm only going to focus on one. And this definition is community engagement refers to the process by which organizations, institutions, or individuals actively involve members of communities in discussions, decision-making, and activities that impact on their collective well-being. Now, we also have to define the term community. So what does community mean? Well, my definition is something that people have in common. So that may be something like ethnicity, religion, disability, living in a particular village. But it's really, really important to recognize that although people may have something in common within that community, they also have differences. And we have to recognize intersectionality. So for example, Indigenous women, there's the intersection of both being Indigenous, but also being women. So their experiences, the experiences of Indigenous women, may be different from the experiences of Indigenous men, but they also may have things in common. Community engagement normally involves open dialogue and enables diverse voices to contribute to shaping outcomes. Community engagement is often viewed as a bottom-up approach as opposed to a top-down approach. And this is a bottom-up approach because how we're viewing the community is as experts with experience, i.e. lived experience. This contrasts with a top-down approach where professionals, for example, are seen as or as positioned as experts because of their professional knowledge. So as I've already said, community engagement can take many forms. It can be the passing on of information to bring about change. It can include seeking the views of the community to inform decisions that practitioners may then make. It also includes communities having decision-making powers and leading projects. Other ways I've seen community engagement occur is in the teaching of professionals. And this is where experts by experience, for example, autistic people, will be involved in the training of social workers to ensure that social workers are fully aware of what they require. Community engagement is said to have many benefits, including raising awareness of health promotion initiatives, to learning from communities about their needs, which can ensure that services are responsive to these needs. This in turn may lead to increased uptake of services, improved satisfaction, improved health literacy, and improved health outcomes. But it's always important to think about, why do communities get involved in community engagement projects? What is in it for them? Well, there's many reasons. And some people get involved because they want to have their voices heard, and they feel that their voices are not heard and that services are not responsive to their needs. Where others may engage because they want to bring about change. And that is what a lot of people get involved for. They want to make a difference. They want to bring about change to improve their lives and to improve the lives of their communities. So now that I've said a little bit about community engagement, I'm going to give some examples from some work that I've undertaken on Indigenous communities, primarily in low and middle income countries. The first example is from an integrated review on access to maternal and neonatal care for Indigenous women in low and middle income countries. And it illustrates some of the issues that arise from not engaging with communities about their experiences and their needs. So the main findings of the integrated review was that there was a lack of fit between the biomedical model or biomedical procedures that were offered in health facilities and community, cultural, social and religious traditions around childbirth. This led to delays in accessing maternal care. For many women, for many Indigenous women, the biomedical construction of childbirth and the services that were offered were not seen as aligning with their Indigenous identity and expectations. There was limited engagement from maternal health services with community preferences. And these community preferences were for traditional healers and home births. And these were rarely incorporated into the biomedical model. They got a specific service that reflected the biomedical model. Many of the practices in the health facilities did not fit what the women wanted. They did not fit their preferences. And their preferences were for Indigenous vertical birthing practices rather than horizontal birthing practices. They wanted their relatives in the room. They weren't allowed. They wanted to use incense. They wanted to have traditional ceremonies around the placenta. They weren't allowed. And this was problematic because it impacted on their access to services. Health professionals also reported that Indigenous women did not ask questions. They didn't ask questions, but there was no thought to find out why they didn't ask questions, why they were quiet when they were offered these particular health services. And it was the Indigenous women were positioned as being the problem, rather than thinking, well, actually the problem is the health system, the health services that are offered to these women but have no relevance. So this example illustrates the importance of community engagement. The services that were available were viewed by many in the community as not acceptable. They were not relevant. They did not take them up. The situation could have possibly been mitigated if there had been more community engagement and the building of trusting relationships to ensure that interventions not only reflected the social cultural views of the Indigenous women, but also empowered Indigenous people to be partners in the planning of appropriate services that they would use. After all, it's no good having services that nobody uses. Another example is from research we carried out with community health workers, such as auxiliary nurse midwives and accredited social health activists in India. The research identified issues in the take-up of maternal and neonatal initiatives by women from scheduled tribes. And what we found was similar findings. ASHAs and A&M spoke about how some tribal women would not take the medicines they were given, they would not attend for institutional births, that there was a lack of trust, that the women would not tell them about their pregnancies, and that they would run and hide when they saw them. What was apparent was that community health workers, in some cases, were more focused on reaching targets that had been laid down by the government of India than they were on engaging with the community and working with communities to develop relationships. So what we had was more of a top-down approach rather than a bottom-up approach. And the top-down approach came across to the Indigenous women, to the scheduled tribal women, as we have these services, you must use them, rather than finding out actually what did they require. More in-depth understanding of the tribal women's conceptualizations of health and well-being related to maternal and neonatal health, therefore, was needed. Making initiatives more responsive to the needs of tribal communities and their perspectives on childbirth through enhancing community engagement may have supported greater engagement from scheduled tribal women in those initiatives. So I'm hoping we're seeing the importance of community engagement here. Another example was found in a scoping review we undertook on mental health and Indigenous peoples in Southeast Asia. And we found the same kind of findings, really. There was limited focus on Indigenous worldviews. What there was a focus on in these articles was the Western biomedical model and Western ideas about what mental health was. And this is problematic because Indigenous psychiatry and transcultural psychiatry indicates that Indigenous worldviews on mental health may be different to those that are spoken about in the Western biomedical model. So it has implications for interventions that are based on Western models and which are then transported to Indigenous communities as services. Moreover, it also has implications for research. And many of the articles used standard mental health questionnaires which were based on Western populations to measure mental health prevalence in Indigenous communities. So if they have different ideas about what mental health is, that is hugely problematic and questions the validity of the questionnaire, in that it may not be measuring what it set out to measure. This also includes theories of mental health, which are based on dominant ethnic understandings of mental health, or Western understandings of mental health. So again, we can see the issues in not engaging with communities and their knowledge, with top-down or dominant perspectives of health, in this case mental health, potentially resulting in interventions which have little relevance and research which is potentially flawed. So, having looked at a few examples from my research on why community engagement is important, I'm going to focus a little bit more on semi-theoretical understandings of community engagement, participation, and empowerment. So I'm going to use an example from the UK, from Beresford. So Beresford identifies two contrasting approaches to community engagement and participation. The first one he identifies is what he calls a consumerist approach, which is said to be influenced by neoliberalism and new public management. And it emphasizes things like choice, viewing communities as consumers or customers of healthcare. This type of approach to community engagement focuses on consultation, exchange of knowledge, having voices heard, and feedback. In many communarist-influenced engagement projects, community members have minimal say in decision-making. Alternatively, Beresford identifies another form of community engagement, which he calls the democratic approach, and which influences myself. That's the kind of approach that I would tend to use. This is about the redistribution of power and what is called the empowerment of communities to direct change. It focuses on active participation from active citizens and focuses on with and by communities as opposed to on communities, to communities, about communities, or for communities. Democratic approaches are influenced by people like Paulo Freire and Fowles Borda, who are from South America. And they are seen as emancipatory. Participation, therefore, in the democratic approach is not simply about taking part or being present, but is about having some influence over decisions and over actions. So what we have here is a difference between community engagement, which focuses on hearing from communities and exchange of information, and more democratic political approaches which focus on community engagement with the full participation of the communities, including deciding how initiatives are organised and how decisions are made. So as I said, I'm particularly interested in democratic approaches to community engagement, including the co-production of initiatives. And this is what I'm going to focus on next. So many of you will know this ladder of participation. There are many different types of models of participation, but this is probably the most famous. And we often hear the word participation when we talk about community engagement. And this is Arnstein's ladder of participation. And this is often used to illustrate participation and engagement and what counts as participation and what doesn't. So what we have is a ladder, and we have rungs at the side, 1, 2, 3, 4, 5, 6, 7, 8. At the bottom of the ladder, rungs 1 and 8, Einstein says that these are not participation. These would be manipulation or therapy. So an example would be a community member being on an advisory committee, but they have no power. They're just there. Then we have things like rungs 3 to 5. Einstein says these are tokenistic. Although community members' voices may be heard, they're not heeded. They're not influential in terms of decision making. They're kind of just there. For Einstein, authentic participation relates to rungs 6 to 8, where there is partnership, delegated power to communities, or full control to communities. And what you'd kind of probably noticed is that rungs 6 to 8 relate more to the democratic approaches to community engagement. So bearing what I've said in mind, I'm going to use another example from my work in the United Kingdom. Many, many years ago, and I mean many, many years ago, I was a community engagement officer for an initiative called Sure Start. And Sure Start was, at the time, a UK government initiative, and it was premised on being a child poverty initiative. So they were focused on children in the UK who were living in poverty, and they wanted to do something about improving their outcomes, either pregnancy related, developmental related, educationally related outcomes. So what happened was I had this role of community engagement officer, and I had to mobilise the community. So I went off my merry way, mobilising, bringing people on board, and our remit was to decide what services would go into the building and where the building would be positioned. So what you have here is an example of some services and an example of a Sure Start building. Now, the name on that Sure Start building is nothing to do with the Sure Start organisation I worked for. It's just off the internet, so readily available to everybody. So what happened? I mobilised everyone. Everybody was intent on identifying where this building should be situated. We did lots of work, and we decided that the building should be situated within the community that it was supposed to target. And the reason for that was because the community was quite disadvantaged and quite poverty-stricken. And if we had placed it anywhere else, it would have been difficult for them to get to logistically. Having very many children, there wasn't a bus, they didn't have transport, and they didn't have the money to get there. So we proposed that it be placed in this particular community. The Sure Start Management Committee decided not to take this on board, and they placed it within the town centre. This had a massive impact on the take-up of services. So from that particular community, people did not go. So it was positioned as a child poverty initiative, but no one from the particular targeted community went to the building. Instead, what happened was that people from higher socioeconomic situations accessed the building because they had the means, i.e. a car, or the money to access it. This was hugely problematic, and I will talk about this in a moment. So what happened? The decision not only disadvantaged the target community, but ended up alienating them. They felt they had been misled, and that their engagement and participation was a waste of time. This raises ethical issues regarding community engagement in relation to expectations and misuse of power. And my colleague Nevin later on will be talking about ethics and community engagement. So Sure Start management gave the impression of democratic community engagement. That was the impression they gave to the community and myself, and I passed it on. But that wasn't the case. And the community saw this. Afterwards, they saw this, that it was a smokescreen and that it was tokenistic. And I'm going to talk about this a little bit later on when I talk about empowerment. In a moment. Okay. So let's talk about empowerment a bit. So community engagement projects often use the term empowerment and state that communities will be empowered by participating or being engaged in initiatives. The World Health Organization states that empowerment is a process through which people gain greater control over decisions and actions which affect their health and quality of life. However, many projects do not really reflect on what they mean by the term empowerment, and especially the term power in the word empowerment. So the word empowerment is often used without any real understanding of what it means. So what do we mean by power? Well, power is really difficult to define, and there's numerous definitions of power. But I only have time to talk about one. Rowlands defines 4 types of power relations which relate to empowerment. First of all, Rowlands identifies power within. This relates to self-worth and refers to confidence, self-awareness, consciousness raising, and self-esteem, which are important in building the capacities of communities to advocate for themselves. Rowlands identifies power too. This is an individual's ability to act, including increasing capacity to act, knowledge and skills. Power 2 recognises that service users or community members possess the potential to make decisions about their life and the services that they will receive, because they not only have agency, but are experts by experience. Power with relates to collective action. Communities can be empowered through collective action to challenge, for example, challenging hegemonic biomedical discourses to ensure needs are met. And we see this in the disability movements and neurodiversity movements, where collective action has challenged ableist and neurotypical discourses. Then we have the kind of more traditional view of power, which is power over, which is obedience or force. And sometimes we can see this in health professionals' power over service users in relation to access to services or referral and so on. Rowlands would say this is not empowerment. Power over is not empowerment, but it is implicated in empowerment, because if we think back to the Sure Start example, we can see that there was power over the participants. So thinking back to that example of Sure Start, the Sure Start Management Committee used the language of empowerment, but it was not experienced as empowerment by the community, who stated that their engagement was a tick box exercise because of government expectations of community involvement. They had to do it. It was expected. So in relation to Einstein's ladder, many from the community, as I've already said, felt that their engagement was manipulative or tokenistic. It was at the bottom. but they had given the impression that it was at the top of the ladder. Whilst in relation to Rowland's definitions of power, the communities tried to advocate for themselves as a collective, and they had the potential to do it and the skills. So all this kind of power within, power to, and power with was there. But what happened was the Sure Start management had the power over. They had the power to decide that their decision making was the one that they were going to go with, and they could ignore the community's wishes. And that's why we have to reflect upon power, and also power over. Who has the power over to decide? Because no matter how much you empower people, if they are not empowered to make the decisions, raises questions about how are you empowering? And this is where we need to think about, what do we mean by the term empowerment? How will the community be empowered? How will they be powered? So is it that they will be empowered through being, through empower with, empower to, and empower within? Is it that it is enough to have their voices heard if there is no change? Is it right to imply that communities are involved in decisions if that is not the case? I know what I feel, and I'm sure people in here feel the same way as me. So this has led to some authors arguing, and this is mainly in relation to democratic community engagement, that this does not constitute true community engagement. So this includes things like, I'm not going to go through all of them because of time, resources and meetings designed via a top-down approach rather than a bottom-up approach, which involves the communities in all aspects. Occasional meetings and research efforts, for example, surveys, community needs assessments, for input from the community rather than involving them in decision making. Community consultations that only want advice, and so on. And the final one, any kind of final decision that always lies with the professionals. International development organisations, government agencies, academics, and other organisations outside of the community. I would also add on top of this that we have to remember that communities are diverse, and what I often see in community engagement projects are that certain members of the community are involved and others are not. The ones that are not involved tend to be the most marginalised and from underserved areas. And hence, the community engagement projects can reinforce existing inequalities by only engaging with the most dominant in society. We also need to think about barriers to engagement and participation and how we can mitigate these barriers. For example, barriers could include having childcare for women so that they can participate, or particular facilities for disabled people, or payments for Indigenous daily wage earners so that they don't lose their daily wage by participating. So, given my interest in democratic approaches to community engagement, I want to speak about a community engagement and empowerment project that we're currently working on with Embera women in Colombia. Embera women are Indigenous women. Colombia is in South America, and it's funded by the AHRC, the Arts Humanities Research Council, which is UKRI funding body. So the AHRC has given funds to design projects in collaboration with Indigenous communities. So Embera women are co-producing the project with us. They're our partners, but they're also leading the project. And this is throughout the whole project. So the idea at the beginning, the design, the implementation, the evaluation, and the dissemination of the project. And what the project is focused on, which was decided by the communities, was to design guidance to non-Indigenous health professionals on what Embera women would like them to know about what is important to them in relation to childbirth and pregnancy, so as to facilitate services that are responsive to them, but also to facilitate health professionals that are responsive to them. So through discussions with the community, they decided that the best methodology for this was art-based methodology and film and so on. Discussion, stories and the like. And this was decided upon by the community. So this is what we would call a democratic approach. It's a bottom-up approach on the topic. The issue was identified by the local Embera women, using methodologies identified by the women, and the guidance will be informed by the Embera women on what they want health professionals to know. So another project, which I'm coming to the end, is one that we're currently designing in Sierra Leone. And it's a community-led project, and it seeks to improve maternal and neonatal outcomes in underserved rural last-mile villages. And what I mean by last-mile village, I mean they are less likely to have services and they're more likely to be further from a road. So they tend to be very, very underserved. It's a community-led project with villages and with the support of the Ministry of Health and a local NGO. And we're co-constructing the project together. And the aim is to facilitate community members to identify challenges and what needs to change to improve maternal and neonatal outcomes. So we're not going in there telling them what needs to change. We're going in there to understand and facilitate and have them lead the project in what needs to change. What are the issues and what needs to change? So this will bring about locally produced solutions which are more sustainable and community ownership. So we've been discussing what kind of models of community engagement and empowerment we may use, and there's lots of different models, and we've been discussing with community members about which ones are appropriate, and what we may do is design our own with the community. But this is one particular model. It's called the SALT model, which many of you may know. And I always forget what it stands for. Stimulate, appreciate, learn and transfer. Stimulate, appreciate, learn and transfer. And so in the middle you have kind of widening circle of trust, increased ownership. And then at the top you've got home visits. And so what happened in this particular model, this is for a children's immunisation project, this particular design, this particular diagram is from. So what they did, they trained facilitators from the local community to undertake home visits. So they were regularly going around the villages, talking to community members. And what they were doing was stimulating conversations, appreciating strengths, what is good, what is good that we do, and listening to hopes, concerns and dreams. Then they go into the dream building in this particular model. What is your dream? So in this model, it's what's your dream of having healthy children? What is a healthy child? How is immunisation part of that? So the community comes together and starts dreaming and designing what is realistic as well. Then self-assessment. How do we stand currently in relation to this dream? And then in this project, they identified 3 actions that they would target upon in relation to what they'd identified. Then they took action and they followed it for 3 months. They then reviewed it, did some indicators, identified what was effective, what could be changed. And then they all came together, all the different communities came together, they shared their knowledge, and they learned and transferred knowledge. And you'll see this is a cycle, so it goes round and round and round. This is one model that we're thinking about using. It may not be the end model, and we may adapt it depending on community feedback. So to summarise, community engagement can take many forms. However, it's important to be upfront about the type of community engagement that is being offered. It's important to be transparent and what the aim of the community engagement is. Is it feedback, consultation, or will communities be involved in decision making? And if so, to what extent? It's important to reflect upon what we mean when we use the term empowerment, not just using it without any understanding of what it means. And we need to reflect upon the term power. Who has the final decision-making power? How are the communities powered? We have to think about this. What is empowering about taking part in what you say is empowering? Does the community see it as empowering? Why is it empowering? So rather than just using the language of empowerment, like Sure Start did, they used it, but they didn't follow through. They talked the talk, but didn't walk the walk. Let's be explicit about how the project is empowering. Community engagement and empowerment comes from a standpoint which is respectful and values the insights, lived experience and agency of communities, and is also respectful of their time. We need to be aware of who is included in community engagement initiatives and who is ignored, and how we can overcome some of the issues that may hinder participation. Community engagement and empowerment needs time to build respectful and trusting relationships, including being well-resourced. But what we need to kind of think about is that community engagement is absolutely key. As the gentleman from the Ministry of Health in Malaysia stated, it absolutely underpins what we do. Global public health, health promotion, and it needs to be given the respect that it is due, and we need to really, really reflect upon what we mean by community engagement. Are we actually doing community engagement, and are we actually empowering people? So these are my references. The slides are available if anyone's interested. I'm going to just tell you about my book, because why not? But it's already been mentioned, but this is a book myself and Dr. LaPlaca have written, and you probably realise come from a political point of view. So it's called Understanding Power Relationships and the Political Nature of Participation. That's the chapter that I wrote in this book, which has just been published. And another, I'm not plugging myself here, I'm really not, but I'm going to talk about what I know, which is my work. Another piece of work that I worked on was empowering children who live and work on the street in a country in sub-Saharan Africa, which I won't mention for anonymity reasons. But this critiques international development agencies' ideas about empowerment, capacity building and participation. So that was almost 10 years ago. So that's it really. Thank you for listening, and any questions on that?